Welcome back to the deep dive. So, if you've got Porth's Essentials of Pathophysiology open to Chapter 8, maybe looking at fluid, electrolyte, and acid-base balance, and feeling a bit overwhelmed.
Yeah, it's a hefty one, but you're definitely in the right place.
We hear you. This stuff is, well, it's fundamental.
It really is. It underpins almost everything else in clinical practice. So our goal today, we're going to try and map out this whole chapter, fast track it, from how tiny cells manage water to the big systemic acid-base issues.
Exactly. Give you a quick way to grasp the core concepts. Because let's face it, keeping these balances, fluids, electrolytes, pH stable, isn't just important, it's absolutely critical for survival.
Tiny changes can have massive consequences. So we'll hit the three main pillars from the chapter: fluid dynamics, electrolyte balance, and then acid-base regulation. Ready to jump in?
Let's do it. Okay, first up, the basic geography of body water. Total body water, or TBW. Where does it all live?
Right. Think of it as two main compartments. About 2/3 of all your water is inside the cells. That's your intracellular fluid, ICF.
Okay, ICF inside, so the rest.
That last third is outside the cells, the extracellular fluid, or ECF. And that ECF is mostly split between the fluid in the tissue spaces, interstitial fluid, and the fluid in your blood vessels, the plasma.
Gotcha. 2/3 in, 1/3 out. But the key thing is what's in that fluid is very different.
Totally different. Inside the cell, in the ICF, the main positive ion, the major cation, is potassium.
K plus.
Potassium inside and outside.
Outside in the ECF, it's mainly sodium, Na+, and chloride, CLS. They rule the extracellular space.
Okay, but that sounds like a problem waiting to happen. Waterfall of solutes, right? If there's tons of sodium outside, why don't cells just swell up and burst from osmosis?
Good question. That brings us to this absolute powerhouse mechanism, the sodium-potassium pump, the Na plus K plus ATPase pump.
The energy hog.
Exactly. It's constantly using ATP, burning energy, to actively pump 3 sodium ions out of the cell for every 2 potassium ions it pulls in.
So it maintains that gradient. Precisely. It stops sodium from building up inside and prevents the cell from, osmotic lysis. It's crucial.
Okay, so that pump keeps the balance. Now, how do things move around generally? The chapter talks about diffusion and osmosis.
Right. Diffusion is pretty straightforward. Particles moving from high concentration to low concentration. Passive.
Downhill.
Yeah, downhill. But osmosis is specifically about water moving across a membrane, usually through special channels, aquaporins. Water moves towards the area with more particles, trying to dilute it.
Want to even things out.
Exactly. And that movement is what defines tonicity, how a solution affects the cell's size.
Okay, let's picture figure 8-3. If you drop a cell in an isotonic solution, like normal saline, 0.9% ACl.
Nothing happens. The concentration is the same inside and out, so the cell stays the same size. Happy cell.
But if the solution is hypotonic, lower concentration outside.
Water rushes in, the cell swells up like a balloon, potentially dangerous, especially for brain cells.
And the opposite, hypertonic, higher concentration outside.
Water gets sucked out of the cell. It shrinks, shrivels up. Again, really bad news for cell function. Visualizing that shrinking and swelling is key to understanding symptoms later.
Definitely. Okay, let's zoom out a bit to the capillaries. How does fluid move between blood and tissues? There are those startling forces.
Yeah, 4 main forces balancing each other out. You've got pressure pushing fluid out of the capillary that's driven by blood pressure, the capillary filtration pressure.
Pushing out.
And then you've got pressure pulling fluid back in. That's the capillary colloidal osmotic pressure, mostly thanks to proteins like albumin in the plasma.
Albumin, the main pulling force. So if albumin is low, say in liver disease,
then that pulling force weakens. Fluid stays out in the tissues, and you get edema. Big time. There are also smaller forces in the tissue itself, but those 2 capillary ones are the major players.
And anything that leaks out, fluid or protein, gets mopped up by
the lymphatic system. It's the drainage system. Super important. If that gets blocked or overwhelmed, fluid builds up. That's edema.
Clinically, what is edema exactly?
It's basically swelling you can feel caused by too much fluid in the interstitial space. And it happens for one of those 4 reasons we kind of touched on. High capillary pressure, low plasma proteins, leaky capillaries, or blocked lymphatics.
And we assess it, right, that pitting thing.
Yeah, if you press on the swollen area and it leaves an indent, that's pitting edema, like in figure 8-5. It means the excess water is mobile. We grade it usually like +1 to +4, depending on how deep the pit is.
And if it doesn't pit?
That's non-pitting edema. Often happens when proteins have leaked out and sort of coagulated, making the tissue feel firm. You see it with like local injury or inflammation sometimes.
And the key clinical pearl for tracking fluid gain.
Ah, yes. Super simple, super important. 1 liter fluid gain equals 1 kilogram of weight gain. That's 2.2 pounds. Daily weights are crucial for fluid status.
Okay, one last thing in this section, third spacing.
Right. That's when fluid gets trapped in places like the peritoneal cavity silas or the pleural space. It contributes to body weight, sure, but it's lost to the functional ECF. It's not available for circulation, which can be a real problem.
All right, moving on. Sodium and water balance. Sodium is the main driver of ECF concentration, the osmolality. So how does the body control water levels to keep that concentration just right?
It's a constant balancing act. Water intake is mainly regulated by thirst. Simple enough, right? Your brain tells you you're thirsty.
Triggered by high concentration or low volume?
Both, yeah. And water output is controlled by antidiuretic hormone, ADH, also called vasopressin. ADH tells the kidneys, hey, hold on to water, don't pee it out.
So ADH makes you retain pure water.
Exactly. And both thirst and ADH release are super sensitive to even tiny changes in ECF osmolality and the effective circulating blood volume.
Okay, but what if the volume drop is serious, like major blood loss? Is it just ADH?
No, then the big guns come out. The body activates the sympathetic nervous system and, crucially, the renin-angiotensin-aldosterone system, RAAS.
RAAS. Right. Walk us through that cascade again. Low volume triggers.
Low volume, sensed by baroreceptors, makes the kidneys release renin. Renin leads to angiotensin II.
And angiotensin II is nasty stuff.
Oh, yeah. It's a potent vasoconstrictor, jacks up blood pressure, and it stimulates the adrenal glands to release aldosterone.
Aldosterone, the sodium saver.
That's the one. Aldosterone tells the kidney tubules to reabsorb sodium, and water follows the sodium. But, as a trade-off, it makes the kidneys kick out potassium. Save sodium, lose potassium. That's the deal.
Okay, so that's the normal regulation. Now, the chapter highlights two big ADH disorders, the classic.
The classic pair, yeah. Opposite problems. First, diabetes insipidus, or DI.
Not related to sugar diabetes, right?
Nope. Completely different. DI is all about ADH. Either your brain isn't making enough ADH that's neurogenic DI, or your kidneys just aren't listening to the ADH signal nephrogenic DI.
And the result?
Massive water loss, like gallons of dilute urine per day. 3 liters, maybe up to 20 liters. Patients are incredibly thirsty because they're basically pouring out pure water, leading to hypernatremia and dehydration if they can't keep up with drinking.
Wow. Okay, so that's too little ADH effect. What's the flip side?
That's the syndrome of inappropriate ADH, or SIADH. Here, the body is releasing ADH even when it shouldn't be, like when the blood is already dilute, serum osmolality is low.
So the kidneys keep holding on to water.
Exactly. You get water retention, the ECF volume expands, but crucially, all that extra water dilutes the sodium. So the main finding is dilutional hyponatremia. Low sodium, but it's because of too much water, not too little sodium overall.
Okay, that makes sense. So let's talk about the sodium and volume problems themselves. The chapter divides them into isotonic and concentration disorders.
Right. Isotonic means sodium and water are lost or gained together in proportion. So the concentration doesn't change much, just the total volume.
Like isotonic fluid volume deficit or hypovolemia.
Yeah, think vomiting, diarrhea, bleeding. You lose both salt and water. Signs are things like thirst, weak pulse, maybe dizziness when standing up, poor skin turgor, although that's less reliable in older adults.
And the opposite, isotonic fluid volume excess.
That's too much salt and water. Causes could be heart failure, kidney failure, liver failure, maybe too many corticosteroids. You see weight gain, edema, maybe JVD, crackles in the lungs.
Okay, those are volume changes.
Mm-hmm.
But the concentration disorders seem more dangerous, messing with the cells.
They absolutely are. Hyponatremia sodium below 135 millieql means the ECF is too dilute, low osmolality, so water moves into cells to try and balance things.
Cell swelling, especially brain cells.
Exactly. That's why the symptoms are often neurological, muscle cramps, weakness, lethargy, confusion, even seizures if it's severe or happens quickly.
And the other extreme, hypernatremia, sodium above 145.
Now, the ECF is too concentrated, high osmolality, water gets pulled out of cells.
Cell shrinking. Brain cells again.
Yep. Cellular dehydration. So you see intense thirst, dry mouth, maybe sunken eyes. Neurologically, it can cause agitation, restlessness, confusion, eventually coma. Both hypernatremia and hypernatremia are really serious because of those effects on the brain cells.
All right, let's shift gears to other electrolytes. Starting with the king inside the cell, potassium, K+F. Why is the ECF level, that Narrow range of 3.5 to 5.0, so incredibly critical.
It all comes down to the resting membrane potential. Potassium levels dictate how easily nerve and muscle cells can fire an electrical impulse, especially cardiac muscle cells.
So tiny shifts mess with electrical activity.
Hugely. Even small changes in ECF potassium can lead to life-threatening heart rhythm problems.
Okay, let's look at the two extremes. Hypokalemia potassium less than 3.5. What's happening to the cell membrane?
Low potassium makes the resting membrane potential more negative. It hyperpolarizes the cell, making it harder to reach the threshold to fire.
So electrically sluggish.
Kind of, yeah. Clinically, you see muscle weakness, potentially paralysis, constipation, and the big one, cardiac dysrhythmias. It also makes the heart more sensitive to drugs like digoxin.
And the ECG changes. The book mentions figure 810.
Right. For hypokalemia, you look for a flattened T wave, maybe ST depression, and sometimes a prominent U wave appears after the T wave. Sort of a sagging look on the ECG.
Okay, now, hyperkalemia potassium above 5.0, usually from kidney problems, right?
Most often, yeah. Decreased renal elimination is the big cause, or sometimes giving potassium too quickly IV.
And what happens to the membrane potential here?
High potassium makes the resting potential less negative, closer to the threshold. Initially, this makes the cell hyperexcitable, but if it stays high, it actually inactivates sodium channels and leads to paralysis.
Paradoxical effect. But the immediate danger?
Cardiac arrest. That's the most serious risk. Before that, you see the characteristic ECG changes, again in figure 810. Tall, peaked T waves are the earliest sign, like sharp tense. Then the PR interval might prolong, and the QRS complex widens. Eventually, it can lead to ventricular fibrillation or standstill.
Scary stuff.
Okay.
Moving to the divalent ions. Calcium, phosphorus, magnesium. Who's in charge of regulating these?
Primarily parathyroid hormone, PTH, and vitamin D. They work together, especially on calcium and phosphate. And a key thing to remember is that calcium and phosphate levels in the ECF usually have an inverse relationship. If one goes up, the other tends to go down.
Reciprocal regulation. Let's focus on calcium first. It's the ionized form that's active, right? What's its main job related to excitability?
Calcium stabilizes nerve membranes, so low calcium hypocalcemia leads to increased neuromuscular excitability.
We're excitable. How does that show up?
Tingling, numbness, especially around the mouth and fingertips, paresthesias, muscle cramps. In severe cases, tetany, which is involuntary muscle spasm.
You can test for that latent tetany.
Yep. With the Chvostek sign, tapping the facial nerve makes the face twitch. Or the Trousseau sign, inflating a blood pressure cuff on the arm, causes the hand and wrist to spasm, carpal spasm.
Okay. And hypercalcemia, high calcium.
Does the opposite. It decreases neuromuscular excitability and makes everything sluggish.
So lethargy.
Lethargy, muscle weakness, confusion, constipation. Also, because the kidneys are trying to excrete the excess calcium, patients are prone to kidney stones and might have polyuria, excessive urination.
Got it. Briefly, what about phosphorus and magnesium?
Phosphorus is crucial for energy ATP and also for oxygen transport in red blood cells, part of 203-DPG. Low phosphate, hypophosphatemia, can actually cause red blood cells to break apart, hemolytic anemia, and neurological problems. High phosphate is usually tied to kidney failure and mostly causes problems because it drives calcium down.
That reciprocal relationship again.
Exactly. And magnesium. It's the second most common cation inside cells. It's vital for tons of enzymes, including that Na plus K plus pump we talked about, and also needed for PTH to work properly.
So low magnesium can cause problems with potassium and calcium too.
Absolutely. You often see hypokalemia and hypocalcemia that won't correct until you fix the low magnesium first. It's called refractory hypokalemia hypocalcemia. High magnesium is pretty rare, usually only with kidney failure and overuse of magnesium-containing meds, but it causes decreased muscle function, think hyperreflexia, low blood pressure.
Okay, last major section, acid-base balance. This one feels complicated. The main goal is keeping that blood pH super steady, right? Between 7.35 and 7.45.
Incredibly tight range, yeah. And it all hinges on balancing acids and bases. Remember, an acid releases hydrogen ions, H+, and a base accepts them. The key buffer system in the blood is bicarbonate HCO3 buffering carbonic acid H2CO3.
The Henderson-Hasselbalch thing, that 20-to-1 ratio.
That's the magic ratio. 20 parts bicarbonate base to 1 part carbonic acid keeps the pH at 7.4. The body defends this ratio fiercely using 3 lines of defense.
Okay, line 1.
Immediate defense. Chemical buffer systems. Bicarbonate is the main one in the ECF. Proteins inside cells can buffer too. And there's the H plus K plus exchange. If the blood gets too acidic, H plus moves into cells, and K plus moves out to maintain electrical balance. This is why acidosis often causes hyperkalemia.
Instant buffering. What's next?
Second line, rapid response. Respiratory control. Your lungs control the volatile acid, which is CO2. Remember, CO2 combines with water to form carbonic acid, H2CO3.
So breathing faster blows off CO2.
Exactly. Reduces the carbonic acid level, raises the pH. Breathing slower retains CO2, lowers the pH. The lungs can adjust CO2 levels within minutes.
Okay, buffers first, lungs second. What's the ultimate fix?
Third line, slower but more powerful. Renal control. This takes hours to days. The kidneys handle the fixed acids, the non-volatile ones produced by metabolism, like lactic acid or keto acids.
When they do that?
They can excrete H plus directly into the urine. They reabsorb basically all the bicarbonate that gets filtered so we don't lose base. And crucially, they can actually generate new bicarbonate to replenish the buffer system using phosphate and ammonia buffers in the tubules.
Kidneys are the long-term solution. Okay, so the four main disorders, they're named after the primary problem, right? Respiratory or metabolic?
Correct. Respiratory acidosis is when the primary problem is too much CO2, usually from poor ventilation. The kidneys compensate slowly by holding on to bicarbonate.
Respiratory alkalosis.
Primary problem is too little CO2, usually from hyperventilating, anxiety, fever. Kidneys compensate by dumping bicarbonate.
Now, metabolic acidosis. Primary problem is low bicarbonate, right? Either gaining fixed acid or losing bicarb.
Yep. Think diabetic ketoacidosis, lactic acidosis, or even severe diarrhea where you lose bicarb directly. The lungs compensate quickly by hyperventilating. That deep, rapid breathing, so small breathing is the body trying to blow off CO2 to fix the pH.
And metabolic alkalosis. Primary problem is high bicarbonate, maybe from vomiting, losing stomach acid.
Exactly, or excessive antacid use. The lungs compensate by slowing down breathing, hypoventilation, trying to hold on to CO2 to bring the pH back down.
Okay, for diagnosing metabolic acidosis, the Anion Gap comes up. Why is that calculation so important?
The Anion Gap helps figure out why the bicarbonate is low. You calculate it by taking the main cation, sodium, and subtract the main measured anions, chloride and bicarbonate, Na plus Cl plus HCO3.
What's a high gap mean?
A high anion gap means there are extra unmeasured acids floating around that are consuming the bicarbonate. These are things like ketones, lactates, salicylates. The muddy piles mnemonic helps remember them. Methanol, uremia, DKA, paraldehyde, iron infection, lactic acidosis, ethylene glycol, salicylates.
Muddy piles for high gap acidosis.
Got it.
So what if the Anion Gap is normal?
A normal gap suggests you lost bicarbonate directly, and the body replaced it with chloride to keep the electrical balance. So the gap stays normal. The classic cause is severe diarrhea, losing bicarbonate-rich fluid. It's sometimes called hyperchloremic metabolic acidosis.
Super helpful distinction. Okay, last point here. Overall symptoms. Acidosis versus alkalosis.
Generally speaking, acidosis tends to decrease neuromuscular excitability. Think lethargy, confusion, progressing to coma. Alkalosis does the opposite. It increases neuromuscular excitability. So you see tingling, nervousness, muscle spasms, maybe even tetany. Tag outro. Wow, we covered a lot of ground there. We really went from, the basics of water movement all the way to the nitty-gritty of pH buffering.
Yeah.
It's complex, but so critical.
It absolutely is. The sheer amount of interconnected regulation is just astounding. When you lay it all out like that, what really stands out to you?
For me, it's how tightly linked everything is. You can't really change one thing, fluid volume, an electrolyte level, pH, without affecting all the others. The body is constantly making adjustments across all these systems simultaneously.
Yeah, it's not like these are separate boxes. They all influence each other constantly.
Exactly. And maybe here's a final thought for you to chew on as you review this. Think about something seemingly simple, like someone vomiting persistently. They're losing stomach acid, right? So that directly causes a metabolic alkalosis. But they're also losing fluid volume, which kicks in the RAAS system. Aldosterone saves sodium, but wastes potassium, leading to hypokalemia. They're losing chloride too, so hypokalemia. See how one event triggers this cascade across fluid volume, multiple electrolytes, and acid-base balance? It really drives home how interconnected it all is. It's never just one thing.